It's a session devoted to training and quality assurance subjects for cervical cancer, breast cancer and gastric cancer screening. And we will start by inviting Dr. Ahti Anttila for the first speech on cervical cancer training and related needs.
Thank you very much, dear chairs, ladies and gentlemen. So, I will speak a little about approaches that could be relevant also here in the Baltic countries and Latvian experiences on cervical cancer screening. Particularly, I will have some provocative discussion about testing methods and requirements of the tests and consequences of test methods in the population-based screening. So that when thinking of the CanCon, so that as showed earlier already, so that there are many phases like pre-planning, planning and so on. And I think that when we think of cervical cancer screening in Latvia, as we have heard that there is already the population-based screening ongoing, routine program for the whole country. But what I am very much afraid that still there is a very big need also to consider if the program should be modified very, very basic manner, so that the impact may not be the optimal and acceptable at all. And also consider in the same time if there is need to also assess evaluation of modern technologies in the cervical cancer screening program. So that these two questions are in the focus, and this means that then from the program planning point of view, it is just like considering that to take the next cycle to go back to planning, pre-planning, planning, looking to evidence, synthesis of evidence, resources, organizational models, and then maybe to plan for the new pilot to try to solve the problems. When thinking of the cervical cancer screening, it is exceptional in the sense that the impact, also the reduced incidence of the cancer is very high. 80% or even 90% in those who have attended screening. And then also mortality, at least 80%, maybe more, because the impact on mortality is larger than on incidence. And this is because there are certain validated methodologies that one can diagnose the disease already in the pre-cancer phase. And this very simple treatment of pre-cancer then prevents the cancer to come. So that these methods, how these pre-cancers can be diagnosed, they are first this conventional smear test, Papa Nicolau staining, or comparable validated liquid-based cytology test that has in principle similar staining, but are different for interpretation. Nowadays there is also pretty good evidence that there are other options, modern techniques like HPV testing that can be done instead of validated cytology test. I will show a little results, and the impact also to prevention cancer is at least the same, likely better in HPV testing compared to these validated cervical cytology smears. So this is already an old study published showing that, for instance, 3-yearly screening in women 35 and older, or starting a little bit earlier, that follow about 90% decrease in the actual cumulative incidence rate, about the same with 5-yearly screening. The problem is that with 3-yearly screening there would be already a large number of lifetime tests, so it is much more expensive and much more demanding to organize the service than with smaller numbers, lifetime. This is an example of what happened in our country, so that cervical cancer incidence was in a certain level, 15 cases per 105 years, and when screening introduced and became nationwide, so there was the big 80% decrease, and then steadily incidence have remained at low level, and the same for the cervical cancer mortality. This is another example studying from England showing that in fact screening, for instance, below age 25, even though one would diagnose precancers that are clinically similar to precancers in older women, does not help to reduce the incidence. We don't completely understand why, but even though frequently treating precancers in this like a very young population, diagnosing high frequency of precancers is not similarly effective and treatment of older, let us say 30 or 35 and older. So that all that affects also the balances, so that if a precancer would develop to cancer, so the average it would take 10 to 12 years. Therefore, with 5-yearly, 3-yearly screening, there are already several opportunities to get it as a precancer. And it's very rare, extremely rare, that the cancer would go in shorter than 5-year interval. But then the progression probability is another aspect, so that in young people, so the progression probability is rather low, and most of the precancers would heal themselves spontaneously even without the treatment. And with papillomavirus testing, nowadays it is possible also to find the disease before precancer and the infection, when the HPV infection is there persistently. And then that even gives opportunities for longer times to see the development from normal test result up to precancer. So this is very brief summary, so that I just show these documents that are there, that I based my presentation available from the internet also, so that we have summarized these quality assurance guidelines, taking into account the natural histories, organizational issues and effectiveness issues, and giving recommendations like policy, more organization models, test methods, and management protocols, and also monitoring indicators. And this HPV supplement that was published in 2015 then supplements the earlier guidelines that took into account only cytopathology-based screening, also to consider HPV-based screening and implementation of HPV vaccination. Already in the 2008 edition, so that there were laboratory guidelines for cytology and cytopathology. So it is very clear in these guidelines that this adequate handling and staining of the samples is crucial for the quality and impact. In fact, only the standard or modified Papanicolaou staining protocols have been recommended. No other staining method is acceptable in the guidelines. And this was based on the literature reviews looking to validity, so that this conventional screening, we could find lots of studies, cohort studies, case control studies, population-based trend studies showing the impact. And for liquid-based, with the validated methods, the evaluation was not based yet on studies on outcomes, but in CI3 information that was very comparable to standard studies with standard Papanicolaou methods. For other potential staining methods, there were not such evidence base available that would provide possibilities to recommend them. For HPV screening guidelines published 15, I just summarize briefly that this is nowadays valid in the EU, so that the member states should really consider if even in the case that there is high-quality population-based screening using cytology, even consider if the program could be improved with HPV testing. You can find more advice there. What is also interesting that we looked in these supplements also the invitational strategies that are relevant for the either cytology or HPV testing, so that in fact the level of evidence of these rather simple recommendations how to invite is very high. So that level of evidence 1 means that there are several randomized trials or systematic reviews showing evidence for the statement, so that free of charge or subject only to limited charge, scheduled appointment when inviting, and user personal reminder, and also preferably second invitation reminder, so that there was a level of evidence was in the highest category, and then also the importance for the recommendation, the strength of recommendation was also in a very high category. Okay, so that when we think of the current burden of cervical cancer in Europe, there are still a large number of cases and deaths. In these well-to-do parts, northern, southern, western Europe, historically the mortality rates, they were somewhere in 6 to 7 on average of the regions. And now when the screening programs have been implemented in 60s, 70s, the burden has decreased historically to about 60%. If these recommendations, the guidelines would be implemented throughout, so that there is still space maybe to halve the current burden from cervical cancer deaths. But what is very interesting that in Central and Eastern parts and former socialistic countries, there is very little, if any, decrease in the mortality trends historically. And why is this? And if these countries also would learn to use these guidelines appropriately, there would be enormous benefit at stake for the population. Examples of screening policies. These are mainly from EU member states, but we have collected data also from some other countries. What is very astonishing that when we look target age, screening intervals, years that could be compensated lifetime, there's large variation in the member states. I took here just a few countries and Slovakia as an example. In those times, this was published 5 years ago, that didn't have a population-based screening but had enormous amount of smear consumption because they had annual testing from 18 years onwards. Overall number of tests in Slovakia was much higher than in Finland, either in the population-based program plus screening outside the population-based program. So the question is not that Slovakia did not have smears. Then later on also in Slovakia, further planning has been taking place, and screening policies and test methods have been under change. But this is showing trends in cervical cancer mortality from some selected countries. In Finland, for instance, you see that in the bottom, I don't have a pointer, so that the developments since 1970 already have been pretty nice, so that we are now below level 1. And still in many of these countries, like Czech Republic or Slovakia or, for instance, Latvia, there is no historical change in the trend, even though even more smears have been used than in Finland. This is another report that we had done with the JARC about the cytology uses in Belarus that is not far from the Baltic countries. So that this report has been prepared together with the Ministry of Health of Belarus, showing that very high annual capacities of the test in the female population have been introduced. About 90% of the target population has been tested on an annual basis nowadays. And these are the numbers of cervical cancers diagnosed in the program. The coverage increased, also the number of the cancers diagnosed in the program has increased. But this is the impact in the population, or demonstration that there is no impact in the country. So that enormous amounts of tests consumed, large number of cancers diagnosed, but no preventive impact. And this is also a recent study from Latvia here in Riga, published last year, showing also that from the current cervical cancers, in fact, large number of cases have been screened earlier, and still the mortality and incidence levels are very high, and it just looks like the preventing impact is very poor. It is really worrisome and just demonstrate that there is a quality problem in cervical cancer screening. What can explain this kind of trends? So sure that there still remain large proportion of women unscreened that causes some limitations in the impact, and also same time some women are overscreened all the time. But the most serious explanation is that there is sampling and or diagnostic error in the screening test itself, so that many of the countries have documented that they don't use the standard Papa Nicolau staining in their cytopathology, but some other things that are not validated and are not recommended either. And then if there is an error in the test, it then leads also to difficulties in the management. If the screening test is not valid, then how you get the right women for valid management? How can you guarantee that the quality criteria in management are right? And still also cancer treatments may be different in different countries. Not all the countries have all the good resources for cancer treatments. So these are the elements and failures. This is very, very serious problem, and it is a pity that we don't have more information about this, so that we should have some linkage studies between screening records, cancer registry records, that we would really validate and demonstrate that this sampling and diagnostic error in the screening test is the main reason. Now we have to do this only based on reported statistics on screening and reported official burden of the disease in the population. So what should we do? Sure, training is one issue, and I just saw what are the qualifications nowadays in our program. Sample taking, we use nurses or midwives or sometimes public health or laboratory nurses, so they have really good basic training, continuous training also at work. And also we, in our program, in our country, gynecologists or GPs could take the sample, but not in the program, that is just for services outside. Inside the screeners, they are in our laboratory specialist nurses or nowadays bioanalysts and basic training 4 years, and then continuous training before qualification for the work and then during the work. Cytopathologists and histopathologists, they are medical specialists, 6 years to get medical degree plus 5 years specialist training to get the status. And then also continuous training at work. Colposcopy is also 6 years plus specialist in gynecology. And same is also for gyne-oncology. So that these are about the basic requirements before becoming validated to get licenses to work for screening program. And also we have other staffs like epidemiologists, public health specialists, GPs, and so on, that varying from master degree to doctoral degree or specialist degree. Examples also specialists in pathology, and including both cytopathologists and histopathologists. They have common training nowadays, and our pathologists work both in cyto and histopathology. So this is specialist training after done the basic degree, medical degree. So that they have to learn the theoretical and practical knowledge, understanding in pathophysiology and diagnostics. They have to get abilities to interpret the cytological, pathological samples, perform autopsies, interpret their findings, really to be able to find causes also. That's appropriate knowledge on histochemistry, immunohistochemistry, molecular biology that are nowadays increasing amounts used also in pathology. And they have to learn good skills to supervise the laboratory, including IT, quality assurance, organizing multidisciplinary clinical pathology meetings, and also they have to have good skills nowadays on research. So that these are about the basic requirements that we think, and so in addition to this specialized training, so this is also taking place in the tailored training at work. And this is an example of training in colposcopy that has been prepared together with the Finnish Association of Colposcopy and the European Federation for Colposcopy, so that qualifications to become a colposcopist have this specialist degree or being in a specialist training program to do the examination, a web-based examination, and current guidelines, Finnish guidelines in this example that are in line with the European guidelines, and then preferably basic colposcopy course organized by the European Federation for Colposcopy. And then there are also many skills that affect to work up in the work that need to be included then to get a certificate. Well, when thinking of the training needs of a country like Belarus or Latvia or Slovakia, so there are many challenges. How to plan the program right. I don't deal so much with those issues. But in brief, so that first there should be the nominated national screening coordination that would plan and lead all the later phases, also training, and also would collaborate with the screening evaluation units. It would be very useful to have also the common training course on generic issues in cancer screening. We have planned in some earlier joint actions this European schools screening management, that is a 2 weeks curriculum about all the generic issues. This could be very helpful in these settings, really, to build up consensus building between policymakers, screening coordinators and evaluators, key clinicians and stakeholders, also key medical associations that have responsibilities a lot. And then when thinking training, so that training should be done for the first part in the planning phase for the pilot, so that the screening coordination teams, evaluation teams, and these key clinicians in those units that will run the pilot need to be trained first, and these units can become later on the reference center. And only when the pilot is successful and then the program is expanding, then these reference centers could tackle the training and other quality assurance indicators and practices to broaden then the rollout and evidence-based and screening to the national basis. So this is about the scheme that we have thought that we would like to propose for these countries. And then don't forget to have continuous training also when running the program. So the training, quality assurance audits, all these should be a continuous process, part of the program. So to discuss and conclude, quality improvement in cervical cancer screening is a very important requirement in this a large number of countries in Europe, also in the European Union. And so it means that this new quality improvement cycle needs to be started from pre-planning to replanning. And this is that we would like to really support also from the CANCON group and European Quality Assurance Guideline groups. Use only validated methods and protocols, organize the services appropriately through all the steps, also in the invitations, using the test systems, and also in the patient management. Training first the key staff and then plan the pilot, and if there are needs, you can also consider planning the key staff training abroad. Like in colposcopy, I have heard that there's already have been a very good training program together with England, and so that the working procedures, diagnostic criteria, and so on, they are already okay. But similar things should take place also for other professionals in histopathology, in cytopathology, because they all have to work together as multidisciplinary teams. And sure that there may be already some clinicians in the country who have done this and who know already the working procedures, then it is even more easier. But if there is nobody available, then please consider also some international visits or training programs, and also shorter-term courses and degrees. And then when going to piloting and rollout, then continuous monitoring and audits are really necessary. Otherwise you will not be able to maintain the quality, and then the training should be integrated to these phases of the program. Okay, this was all I wanted to say. Maybe you know more than I know about the current situation in the country, so that what I have looked is just what I can find from the literature and earlier visits, but I really hope all the best success for this exercise. And if indicated, so I think that we can say that in many of the European countries we would like to really support and collaborate also with your countries to really to find the best solutions for cervical cancer screening and prevention. Thank you.
Thank you for your presentation. Actually, a couple of years ago, we evaluated our cervical cancer screening program in the Disease Control Center, and you pointed all the main points which we also found to be weak in our cancer screening program. What do you think, if we have to start with something tomorrow, what is the first what we have to do?
Yeah, it is really difficult to know. Like with Belarus, we thought, should non-valid screening stop completely, or should it continue? And what to inform the woman who have given a smear and got the negative result? Can you inform that now she has been protected or not? I don't know. And I'm happy that I don't need to make the decision, but you have to take here in Latvia for your own program. Should you stop or not? That is the first question. But what you can do tomorrow, that you can decide that let us start a new cycle, and let us provide resources now for the management team and planning process, and involve all these key clinical organizations, come together and recognize where we are and make the plan together, and also get the acceptance by the ministry.
And all three cancer screening programs should be evaluated together or each separately? What do you think? Because we have three.
Could you say?
Should all three organized cancer screening programs evaluated together or separately?
Well, I would say that there are synergies rather than they have to do all together, so that there are synergies. There are some similar problems in any cancer screening program, but there are also some dissimilarities. And you have in certain cancer screening program, you have different specialties involved, so that as I showed earlier, the governance models, that you need different levels. You have one committee that takes into account all screening programs at certain level, but then you need also certain coordinating teams that are running just particularly specific for each program.
Decision should be made on political level.
Decision should be made on political level, but with good understanding also of all key medical associations. So that, because if there is no consensus and somebody is against, there is a danger that then even more delays will take place until the quality assured program will be in place.
Because we have one very strong point. We started very good colposcopy service development in Latvia, and also we developed those colposcopy centers, which can be also like referral centers. And we also introduced multidisciplinary approach, so we have something to start from. And thank you that you have been nearby all the time, because you were the first who came to Latvia before we started our cancer screening program, and thank you for your support.
Yeah, thank you. And I think that's in Slovakia also. I visited there for WSH Europe a few years ago. They also had very good colposcopists, and even the colposcopists had done the plan for the population-based program, but still the program was not accepted quickly, and therefore the country still struggled to get all the quality elements in the program. So that I think that colposcopists, gyne-oncologists, they are in a very good position, because they see the patients and they understand all the processes that are there. But there need to be also the consent.
Also, we understand the training needs, starting from obtaining of cytology and for students, for doctors, and so. Any other questions, please?
I have no question, just a technical comment to figures you showed. In the Czech Republic, this screening program does not operate well. And it's not a problem of skillfulness or skills of physicians or pathologists, but it's a problem of setting of the program. And the program is completely in hands of gynecologists in the network of primary specialists, and they completely miss the age cohort of women older than 45, 47 years, completely. And these women usually stop regular preventive examination in gynecologists, and they are moved to GPs, and so they are missed by the screening program. So we must redesign this, and the only way how we can do it is we had to involve health insurance companies, because they have executive power to control patients. They can invite directly older women. As you know, the incidence of this disease is bimodal, and the second peak in the incidence generates the mortality rates you saw in excellent speech of Ahti. So that's the story of the Czech Republic.
Yeah, but in many countries the problem is that the cytopathology laboratory responds to gynecologists who then informs women. But if there is the need, a referral to colposcopy, it often happens that the gynecologist, him or herself, make the colposcopy at their own unit, but not in the mandated colposcopy center, that is the regional center in the program. This means that there are programs where almost 70% of those women who are referred to colposcopy disappear from the program, and it is not known if the colposcopy was done or the colposcopy was done appropriately. If you do it too aggressively, then you induce harm, and you have to use these reference centers for colposcopies also. And this is a big problem in many countries, and then this health insurance system still pays the colposcopy, even though it was not done in the reference center. And in some instances, the gynecologists can even earn more from this non-program service than the program service. So that I agree that you have to involve also the health insurance and also all the databases, but still you have to be able to use the databases similarly as you use the screening register, to be able to monitor throughout the program and then also validate that the working method is appropriate, and link the data also with external registers.
Thank you so much. So we have to proceed. The next speaker is Stefan Lenneberg from Norway. my co-chair, and he's going to speak about quality assurance in cervical cancer screening. Please, floor is yours.
Thank you very much. So I will continue on the quality assurance theme, and some of the themes I will touch on will be repetition, but I think we can survive some repetition and even maybe benefit from it. Let's see if I can find my... there. So as background to quality assurance, we have the European Union Council recommendations on population-based cancer screening from 2003, and they are in fact quite good. So if you have not read them and become acquainted with them, I suggest a read-through could be useful. There's some principles that are useful for the planning of cervical cancer screening programs. And then, of course, the European Quality Assurance Guidelines and their supplements coming out in 2015 that detail on the European level a lot of the things that need to be done to achieve the optimal effect of cervical cancer screening. So quality assurance really is an integral and an ethically mandated part of population-based cancer screening, and this is important to realize. So what do we need by comprehensive quality assurance? Well, it means that all of the aspects of a screening program should be covered by the quality assurance processes. That is the policy, the screening policy we have, the organizational structure of screening. We need to quality assure the coverage, adequate coverage of the target population, the validity of the screening test, and crucially also the compliance with the screening algorithm and the recommendations based on the test results in the screening program. Then when we have screen-detected lesions, the adequacy of the follow-up and management, the treatment, is important to realize also that the effect of the screening program. So we need to have evaluation of the effectiveness, not only the effectiveness but also the harms to adverse effects, so that you can have an optimal balance of benefits and harms in the population-based screening program, but also the cost effectiveness, which is extremely important to be able to realize the screening programs. All these three aspects have as a component the effectiveness, so really the cancer outcome is crucial for all of these evaluations. Another way of looking at it is the screening chain itself, which is a chain of events, and the screening chain is a good picture, because to be able to realize and come to the preventive effect at the end, the screening chain is only as effective and only as strong as the weakest link. So even if you have complete coverage of a target population, but the validity of the test itself is poor, or you have a lot of dropout from screen positives, you will not be able to realize the cancer preventive effect at the end. And why do we do this? Why do we do quality assurance? It's not just an academic exercise. It is to be able to provide feedback to the screening providers in order to effectuate corrective action. So that we want to have a quality cycle with incremental improvement of the quality of screening. And how do we do this? Well, already almost 200 years ago, Florence Nightingale knew our ultimate goal is, of course, to maximize quality, to manage quality, but you cannot manage it until you can measure it, and you cannot measure it until you can monitor it. So the collection of good quality data on the screening processes is crucial for all this activity. You have seen this already before. These are the first three recommendations in the screening package of CanCon, work package 9. The first one is, I want to show it and even say a few words about it again, because I think it's really crucial. I think the governance structures really are a key barrier in many screening programs that have challenges to realize effective population-based screening. Another thing is that the legal frameworks must be in place, because if the legal framework does not allow you to collect the information you need and do the linkages you need, then you will not be able to do the quality assurance. So the legal framework, the assurance that the legal framework provides the possibility to do the quality assurance activities should be linked with the decision to start a population-based screening program. And finally, again, that quality assurance should have its own budgetary post to ensure that the resources necessary are available. This you have also seen before. These are the different aspects of quality assurance, and that could be then covered by the 10 to 20% budgetary post. Indicators from the European guidelines that are correlated with the outcome of screening. The first one, and maybe the most important one, at least in established screening programs, is the coverage by examination of the target population. That might be the main determinant of success. But too frequent testing, if you have a small interval and you increase the intensity of screening, if you have poor quality of screening, you will quickly lose the incremental benefits of intensifying screening, but the harms keep increasing, probably close to linearly. And of course, if you have downstream failures in the screening chain, then you will not be able to realize the benefits of screening coverage. For example, in the form of false negative screening test results, the dropout of the follow-up of screen positives, or ineffective treatment and surveillance. There are also in the quality assurance guidelines evidence-based recommendations on how to increase and optimize coverage of the screening programs. There was a survey of 29 European countries published in 2015 by Elfström et al. That lists a lot of different aspects of organization and quality assurance activities in these countries of cervical cancer screening. And in that particular publication, they listed 4 countries only in Europe which require co-payment for cervical cancer screening. One of them was Norway, another one was Latvia, but I have just talked to daļa here before this talk, and it seems that in Latvia there is no co-payment, so unfortunately, or fortunately, Norway stands alone here now. Invitations with scheduled appointments are proven to increase the uptake, so this should be implemented if possible. Also, regular monitoring and reporting of coverage can drive improvements in this respect. And of course, then repeating the invitations and reminders also increase participation coverage. Self-sampling is another method that has been tried and also implemented in some cases already. This is one pilot that was done in Norway in our program. Because in Norway we don't have scheduled invitations, they're open, and this is for women that have not responded to the primary invitation to screen, so they are already a hard to reach population, and they receive an open reminder 1 year after the primary invitation, and usually in the program the response rate is about 20%. Adding only the pre-scheduled time and place to this invitation doubled the participation rate immediately, and it was consistent across 3 very different screening centers and across all the target age groups. In the supplements coming out in 2015, also some benchmarks for some of the indicators have been proposed or recommended, so that invitational coverage should be close to complete in the target population. And examination coverage, 70% is an acceptable level for cervical cancer screening, and 85, and more than 85 is desirable. The next set of indicators relate to screening test performance and include proportion of repeat testing, proportion of referral for colposcopy, and also the positive predictive value, and the specificity of the screening test. You can also monitor the proportion of inadequate tests, which also describe a little bit the quality of testing. Indicators related to diagnostic assessment and treatment include, crucially, the compliance to referral and management recommendations, and detection of histologically confirmed CIN lesions, and the management regimes of high-grade lesions. This is an example of compliance with referral to colposcopy and biopsy in Norway over time, and we only reach about 80%, so 20% of this very high-risk population is lost to follow-up in Norway. Some of this might be some problems with registration, but by no means all. This is from the European, I have stolen from the soon-to-be-published European Union status report on cancer, cancer screening programs implementation. And here the project, the undertaking has collected a lot of data from indicators from the European Union countries. Unfortunately for Latvia, we see that the completeness on information on referral to colposcopy on screening tests is not available, the monitoring information on that. So also all the downstream indicators, detection of screen-detected lesions, CIN lesions, positive predictive value, and test specificity will then not be available. Especially in breast cancer screening, you can open the newspaper and see something like this. Screening is turning healthy women into patients. And we as screening managers, we need to have a response to this. And the response is that we need to have evidence and data on the effectiveness of the screening program we have. So guidelines and studies in research settings in other populations do not provide the full answer. So we need to have information about how the screening program in our current setting is working. For this, we need linkage to the outcome, that is the cancer register and cancer outcomes. If you do that, we can then start to produce indicators such as cancer incidence in the screening interval after non-participation, after the negative smear. So if you have sensitivity problems with your screening test, then this will give you an answer on that, borderline or referrals. Also, you can make a case control audit on the distribution of screening history among cancer cases compared to controls. This way, you can identify and prioritize the potential quality improvements that need to be made, and then start a program of incremental improvement of the program effectiveness, and also improvement of the cost effectiveness and the balance of benefit and harm. This pie is the result of such an effort in Norway, where the whole pie represents all the potential cervical cancer screening cases in a counterfactual scenario of no screening. So we project that 70% of the potential cancer cases are prevented by screening in Norway at the moment. And these three slices of the pie are those remaining cancer cases that we observe at the moment. So they can be roughly divided into three failure categories. We have those, half of the remaining cancer cases among women that are participation failures. They did not participate, they're underscreened. A third of them are sensitivity failures. They had a normal screening test but still developed cancer. 1/6 are follow-up or compliance failures who have had a positive screening test but something has happened and the screening program, downstream in the screening program, was not able to prevent the development of cancer. If you go into more detail, you can see what kind of follow-up these women had. For example, after a high-grade primary screen, there were delays in the follow-up, unsatisfactory follow-up, negative histology and no follow-up after that, positive histology but then a dropout and no treatment. This happens also. And then also CIN treatment, CIN treatment, but no follow-up, and then cancer has evolved. And these are the odds ratios. We have also the same for control, so we can calculate odds ratios for the association of this type of a failure and the risk of cancer. And so, for example, if you do not participate, compared to a woman with a negative screening test, your risk of developing cancer in the next 5 years will be threefold. If you have a positive screening test and your follow-up, you have not a compliance with the follow-up, you will increase your risk by 60 times compared to a woman with a negative screening test. In Finland, a similar exercise shows that the follow-up and compliance after negative screening or after positive screening is much better. It's several times lower, the amount of cancer cases we find in these categories. This is for incidence, and if you look at mortality, then this type of screening failures are almost non-existent. So comparing these two countries, we see that 1% of the remaining cancer cases in Finland have a primary referral in the last 5 years, while in Norway, this is 6% of the cancer cases have a primary referral in the last 5 years. So there's clearly some organizational differences why this happens. One, I'm sorry to say, might be that in Norway, when you have a positive screening result, the laboratory sends the result to the GP, who then has the responsibility to take contact with the woman and make the decision to refer her to further diagnostic confirmation. While in Finland, the cytopathologist, when he sees the positive screening result, refers the woman directly. So there's one link less in the chain. One crucial thing is that that you also can do is when you do this kind of linkage of outcome and screening history, is to send lists of potential false negatives to the laboratory for rereading. In this way, especially if you do it blinded and mixed up with controls, you will be able to produce measures of test validity, and you will see if you have a quality and validity problem or sensitivity problem with your screening test. As a summary, quality assurance and comprehensive quality assurance is an ethically mandated and not an optional part of population-based screening. And there are three main things that I tried to put on this slide. I realize now that there's many more points, but three main things is that take-home messages, if you like, is that you need to have data and indicators to cover the whole screening chain, not just part of it. You need to have the ability to do linkage to the cancer outcome, and you need to use this information to produce feedback and to precipitate corrective action so that you can act on the information you gather and produce incremental improvement of the quality of your screening program. And this is a continuing revolutions of the quality cycle. But to be able to do this, first you have to make sure that the necessary frameworks exist. So you have to check that the legal system allows this activity. If it doesn't, then you cannot even start to do it. You need to have the financial and also the organizational frameworks to be able to do it. Thank you very much.
Thank you, Stefan. There is no doubt that we have to have quality assurance system. We have some elements of that, of course, but we have to improve for sure. What approach do you suggest for us to start with tomorrow?
Well, I think that the governance structure really is the first step. That like what Ahti was talking about, that you need to have
managemental team for screening and to see everything, databases and then
you have to have
screening registry and cancer registry.
Yes, and you have to have someone who has the mandate to organize this and also the responsibility to make it happen.
How big is team in Norway, for example, for management of screening?
In Norway, the management team is 5 persons. 5.
What's the population of Norway?
5 million.
5 million.
Yeah. So it's not. We don't use a lot of resources, but there is a good link. We have an advisory board that convenes 4 times a year. That includes representatives of all the professionals that are involved in screening. There's also at the ministry a steering board that convenes several times a year, that sets the goals and the aims of the program, and also makes sure that the frameworks, the legal and financial organizational frameworks exist, that those aims and goals can be realized. And that has a direct link then, of course, to the policymakers at the ministerial level. So this is So there is sort of a chain of command all the way from the screening providers, through the screening management team, through the steering board, and to the administrative and political leaders.
Okay, we will ask for your advice, maybe. More questions? Lūdzu.
Thank you very much for your presentation. It was very interesting. I have a question about test failure. You showed that in Norway it's about 6% false negative results in cytology lab. Is it correct?
The 6% were
From cancers.
Of the cancers.
Yes.
They had a positive screening test. So it's not a test failure, but it's a follow-up failure in compliance with the follow-up.
Okay, but I understood that there is also mistakes in
Yes.
interpretation. So positive tests are interpreted like negative.
Yeah.
Is it correct?
Yeah. So
and this is about 10% of cancer cases.
This is 10% of all the potential.
Screened cancer cases. Yeah. So I will not discuss the staining procedure, of course, because you are using only validated methods. We all in all laboratories in Latvia should take part in international quality control system. We take part in lab quality, well known. And what we can see from the results of all cytology samples, gynecology samples, about 200 laboratories for different cases, or it is inflammation, or it is a cancer case, or it is normal finding, or HPV, we can see quite equal distribution from normal to cancer. How you can explain it? What is your comment about this situation? Because this is failure of interpretation. It is not failure of staining. Is it validated or no? Because my opinion that validation for staining is only agreement with histology finding. This is the main validation. But how you can comment this situation with interpretation of equally stained preps, which all laboratories receive electronically like pictures?
You mean all laboratories in Latvia?
No, all laboratories in lab quality system.
In laboratory system?
Yes, lab quality. This is quality control system, international, from Finland, and we also take part in this. And what we see, there are all results from all laboratories.
Well,
it's very interesting.
Yeah, I cannot comment on that.
They use validated staining methods.
Well, of course, I mean, this normal screening test, this can also be, it's not only interpretative error, it can be sampling error, it can be that the screening test itself it's not possible to detect a precancerous lesion at this stage. It can be an error of sample preparation, staining, interpretation. So there are many different possibilities from where this comes from. It's not only one reason. But of course, if you want to know how your screening test performs for cancer prevention in your program, then the linkage to the outcome and doing this kind of an audit, and then doing the re-analysis of the potential false negatives, that is the clearest and most best to interpret.
Of course.
Yeah.
Thank you. That's why I want to address also my comment to Ahti. Oh, sorry. That despite we are using not validated method of staining by GIMSA, the percentage of our finding is the same as, for example, in England. Yeah, in screening. Is it correct, Dr. Georgica? Yes, but the uptake of screening is also incomparable with England.
Okay. Thank you. Probably we can continue such discussion very long, but we have to proceed, so time is running. Thank you, Stefan, once again. And next speaker is Peter Dean from Finland. Yeah, please. And you are going to talk about training and quality assurance in breast cancer screening, please.
No. We have a frozen arrow here. I'm sorry. How do you unfreeze an arrow? Thank you. Okay. Ladies and gentlemen, we're moving to another cancer this time, and I'm a radiologist, and will add my own comments in addition to those already made today. I've been trying to remove things that have already been said more than once. But we have to think always why we have the quality assurance, and it's to determine, are we successful? If we're doing something right, to try to do it better, determine the weaknesses, and correct them. And it has to be done by monitoring, because the people who make the mistakes, they don't realize it. And this is the Dunning-Kruger effect, which I hope all of you are familiar with, that people who don't do it right don't realize they do it right. They think I'm doing it fine. It also explains, I think, the latest presidential election in the United States. You know, or Brexit, for that matter. Yeah. Yes, they're two similar phenomena. You know, it's tragedy in last year. But training in quality assurance in breast cancer screening, I mean, we all agree it's important. That's why we're here today. But the programs are successful if the cancers are diagnosed earlier and treated with less debilitating surgery and adjuvant therapy. If we detect them earlier and give the same treatment, we may not even get any different outcome. We hope we do, of course. But it's so closely related to the expertise and the performance of the professionals who are involved in these very important decisions, the pathologists in cervical cancer screening, and the radiologist in breast cancer screening. And those individuals who are actually making this qualitative judgment, you know, it's just not reading the laboratory result, it's actually looking at an image and deciding, is this pathology or not? They are the key individuals, and their skills are absolutely crucial to the success of the performance of the program. And although we can rely on individuals to keep up their own competence and to obtain it, as most do, not everyone does, and of course not everyone is aware of so that we have to have the monitoring. Now, in breast cancer screening, the program is responsible for the screening examination and the multimodal breast cancer diagnosis, at least the initiation of this, but also should be involved in the interdisciplinary management of breast cancer. Then I will talk about the training and quality assurance, some problems, and give you a difficult case to bring home a lot of the points I'm trying to make. And the scheduling and invitation are very important, and I would like to repeat that if a woman does not have an invitation for a specific day, a specific time, and a specific place, you are not going to get a very high rate of uptake. The double reading with consensus consultation, this is, I think, something that is more specific to breast cancer screening that two radiologists read and independently evaluate, and if they both have the same opinion, either both normal or both call back the patient, then there's no need for a consultation. But if there's a disparity, then they should discuss it, because one of them might be too eager to call back someone who is obviously normal. If you just bothered to look back at the previous studies, it was there before. And also that one of them might have missed it and the other one did find it. At the recall examination, a positive result leads to referral to the interdisciplinary management, and the radiologist in screening should also participate in the interdisciplinary management because they have started the whole process. When a woman is called back, she has already answered a questionnaire, but she is asked about specific details of her history. Palpation is performed. First, at that phase, it is not performed as a screening method because it has such a limited effect and such a very high rate of unnecessary callbacks. We do the magnification mammography, ultrasound, and if indicated, a percutaneous needle biopsy with histopathology. And then referral to an interdisciplinary breast team if the pathology report is positive or suspicious, or if the radiologist thinks there still is a cancer, it could have been missed by the biopsy, and the patient is referred to the interdisciplinary team for a second biopsy, and for evaluation, usually a second biopsy. And there are some localities, fortunately not in Finland, but where screening radiologists do not perform the follow-up examinations. And this was also the situation when the program started in some places. But it's a very important quality assurance criteria that screening radiologists also perform follow-up examinations and vice versa. It's to improve the screening skills on both parts and also skills with handling the follow-up patients. And when the patient is referred to the interdisciplinary breast team, there will be additional examinations that should include magnetic resonance imaging, when needed, repeat percutaneous biopsy under guidance, either by ultrasound, MRI, or stereotaxis. There should always be a preoperative interdisciplinary consultation. For example, in my hospital district, this is the stated procedure. However, the surgeons often complain, well, we're so hurried and have so little resources that we just go and decide ourselves, because that's the way we did in the old days, and we're surgeons and we like to decide things. And this unfortunately leads to a lot of errors. It leads to failure to remove the entire cancer, or failure to remove the cancer at all. And these are things which should also be monitored, not just the screening process, but also the process of the management, so that we try to keep the failed operations to a minimum. in a unpublished audit we did 5 years ago, we found that on the cancers 10 millimeters or less, there were still 10% that were not fully removed at operation, the first operation. Of cancers 5 centimeters or greater, half of them were incompletely removed on the first operation. And what I find particularly disturbing, the surgeons say, oh, that's all right, we'll just operate again. And when I see these patients again and again as they come back year after year for follow-up examinations, I ask them, what was the worst thing? Was it? And they say, well, it wasn't getting the cancer operation, it was that, or the cancer diagnosis, it was that the cancer was not removed the first time. And this is still a part of the entire management, which is insufficiently recognized. Everyone says, well, there are too many reoperations, but there is not so much done about it. That's a little bit beyond the scope of this lecture. And the post-operative interdisciplinary consultation, the radiologist, of course, is part of the team along with the pathologist, the surgeon, and the oncologist. And there will be other examinations, and the feedback information goes to the screening center. And ideally, those who are screening should also be in the hospital performing the evaluations. And this does happen in a couple of countries. There are probably more countries I'm not aware of. It provides the best feedback and the best training. But if there are separate units, which is very often the case, then all of the screening radiologists should regularly attend the interdisciplinary conferences for their own education and on-the-job training. And for those who can't attend every meeting, they should get feedback, especially on their own cases that they have diagnosed. Now, quality assurance and training really cannot be separated, and we should, of course, as has been discussed, we need to do monitoring, and also anyone doing screening should have a very positive attitude toward lifelong learning, because either you get better or worse, you don't just stay the same. So the personnel all need to be receive the best available training. There's the equipment has to be monitored, and this is usually required by law. And regular feedback and review of group performance and personal performance. In most cases, it's just group performance. The individuals are not singled out. Of course, we find out ourselves, we see a cancer, we look back 2 years ago, uh-oh, I missed it 2 years ago, or I examined her 2 years ago, and actually I didn't miss it because it wasn't there, or at least you couldn't see it. It was certainly there, but you couldn't see it. But this takes time, this takes effort, it can be rather traumatic, but it's the only way to maintain expertise and optimize expertise. The radiographers are an extremely important part of our breast cancer screening. If you don't have a good picture, you're going to miss the cancer. And their training is similar to that of the radiologist, and the trial experience, and also participation in the callback patients and refresher courses. And this can be monitored. There's the Norwegians have developed a system for evaluating, and the spot checks can be done, and showing the results of all of the radiographers, and group and individual, and each individual should know which curve is my curve, and how am I doing compared to the rest. And those who don't do well should improve, and those who cannot improve should find a job that they can do better. And this is not only something that goes to screening. For example, one of the largest medical organizations in the world, the Kaiser Permanente, does this regularly with their surgeons. If they have operative complications above a certain level, they are sent to retraining, and after a year of trial, they cannot improve, they are out. And there are 5 people to apply for every job of each person who leaves. So people want to work in a place where there's high quality. And screening radiologists have the same, should have the same exacting training with experience at least 2 years in a breast imaging unit, and participating in management, teaching courses, good teaching courses in screening, good knowledge of breast cancer pathology. This is one of the weak points, unfortunately, that people think, well, I'm a radiologist, why do I have to learn pathology? I mean, it's so important to understand the pathology and the appearance of different pathological forms. And then work as a trial screening as a first reader, and with a more competent person to follow up. And those who do well and also know how to handle patients should then be offered more opportunities to screen. And of course, the examination of the callback patients and attendance at interdisciplinary meetings and refresher courses. This is an example of accreditation examination. They have this in several countries. The British, I think, pioneered this. We had our own about the same time, starting in the late 80s, about 100 to 200 mammography examinations containing unknown number of biopsy-proven cancers, and the remaining normal cases all had at least a follow-up mammogram that was also normal. And we aim for a sensitivity and specificity both of 85 to 90%, and most people who fail the exam fail on specificity. They call everything back just to be sure, and that of course is not acceptable for screening. And as I've already mentioned, that there should be regular evaluation of the recalled patients to determine if both radiologists hold back these patients, and if there's one radiologist who keeps missing every other cancer, something has to be done about it. It's the same as with radiographers. I'll mention a few typical problems. Here's 7 of them. I'll go through them in order. If healthcare providers, as they do in Finland, may purchase screening services based exclusively on giving to the lowest bidder, it of course means the lowest screen. And there are several hundred communities in Finland, each of which can make their own decision who they're going to offer the screening program to someone who does a good job or someone who doesn't charge much. Because it does take up many years to build up an efficient and effective screening team, and it doesn't take very long to destroy it. But continuity is very essential in quality assurance in breast cancer screening. And I have seen the situation where screening radiologists do not consult with each other. They're both very busy, and time is money, and no one's paying me to consult, so we just call them back. And there are reasons for this: poor scheduling, a lack of commitment on the part of the employer or on the part of the radiologist, geographical problems. But if there is no consultation, if either one says it's suspicious, then there is a higher rate of recall, and instead of recall rates on the order of 2.5% to 5%, you get 10% to 15%, as in some situations, and this is really not acceptable without any greater sensitivity of screening. And of course, the radiologists lose a very important part of their continuing education, which is consultation on difficult cases. And if the screening radiologist is not allowed to perform the follow-up examinations and vice versa, the quality will suffer for many reasons. Those screening radiologists who do not attend the interdisciplinary breast cancer meetings because they're not required, it's an indication of a lack of motivation to do a good job. But the attendance can be required as a criteria for getting paid for the work, and that's extremely effective. Those who might work very rapidly to do more cases and get paid more, or to do the required cases and get home sooner, get to the golf course. It's, if people become so fast that they are careless, they really are in the wrong, they're not doing the right work, they're in the wrong business. The organization should enable them to perform high volume of screening at a high level of quality and maintain the diagnostic skills for assessment. And this is something every screening center has to work out. There are no easy answers. Outsourcing screening examination to radiologists located elsewhere, then you get all of these problems added up, and it's an invitation to disaster. Patients who do not attend when invited to screening. This is a problem even in Finland, where we have traditionally had between 85 and 87% attendance at screening, and many others go to a private radiologist because they cannot wait 1 week or 2 weeks to find the results. But having the invitation, personal invitation, having a friendly and helpful attitude, and a lack of unpleasant experiences. If there is a poor environment at the workplace and a very unpleasant radiographer on a Monday morning who squeezes the patient unnecessarily, probably without realizing it, these people may never come back, and this is a tragedy. I give you a difficult case, just to try to bring home these problems. 57-year-old woman had normal screening mammography. 2 years later, she's 59, there's a new finding, and she was fully evaluated. Here she is, this is 2005. By the way, she's still alive. And 2007. And of course, all of you can see the little lesion overlying the pectoral muscle that was detected at screening, and it was definitely not there in the previous screening examination. And this is actually a cover picture on the latest review of breast cancer screening, the IARC handbooks, number 15 on breast cancer screening. It's this patient. But there's much more than is on the cover of the book. Here we have magnification radiography on the right here, and the lateral medial projection. We see the cancer. It's right close to the chest wall. It's in a difficult position for biopsy. On the CC view, it is so far back we can barely see it, if we can see it at all. And I'm still not sure we can see it on these images. It was seen on ultrasound. It was biopsied. I did the biopsy. It was negative. I didn't think it should have been negative. We sent her to the multidisciplinary center where I also worked, and but we couldn't do the stereotactic biopsy because it was too close to the chest wall and overlying the pectoral muscle. So, of course, we did MRI, and you see it here on your right is her left breast. They are close to the chest wall, but surprise, surprise, there was a cancer or a lesion in the left breast. Now, I'm sorry that the arrow is again on strike, so I can't point these out, but I think you can see the one closest to me is the brighter one is in her right breast. And here we see again with the T1 image, the two cancers. Here on the left breast again, and then we did a T2 image on the darker image. We see it's a bright image, which indicates, of course, that it's benign. So we unfortunately believe that without taking a biopsy under MRI, because at the time, this was now a long time ago, we didn't have an MRI biopsy device, and we couldn't really see it on ultrasound. So we got fixated on the right breast, found it on ultrasound, and thought we might see it on the mammogram. It's very difficult to see here. In retrospect, I can now see it, but in prospect, I could not see it. Here's the specimen radiograph, but you can barely see it in the middle of the so we slice these into much thinner slices and radiograph them again in series. Here is the skin piece, and there's no cancer. Here in the center is the cancer, much higher resolution on these specimen radiographs at high magnification. And here in the deepest of the slices is, you can still see it in the center there. The resection was successful, and it was an invasive cancer, grade 2, 11 millimeters, negative margins, the sentinel negative, but of course it's completely removed, but she still gets the therapy. In Sweden, Laszlo Tabar has followed similar cases for 30 years, and some of them were given the therapy back in the good old days and some weren't. And the outcome is always the same. Nobody dies with a cancer that's 11 millimeters or 12 millimeters or 8 millimeters if it's unifocal. But anyway, she got the therapy. And half a year later, here's her chest film, and she's got radiation pneumonitis. 2 months later, another chest film. She has a lower lobe infiltrate, and it was presumed to be from her chemotherapy. We couldn't prove anything. And you can see on the closest to me here, laterally, there's the scar now from the radiation pneumonitis. It's become much thinner. So here she is treated. She's gone through complications of treatment. At 1 year follow-up, the oncologist said, I'm considering sending to mammography, but she did not. She just palpated. So 2 years after the screening, she got another invitation, because even if you have a cancer in Finland, you still get invited 2 years later. And here's the scar from the operation in her right breast, and here's her left breast. So a picture is worth 1,000 words. So what went wrong? Here it is, 4.5 centimeters in size. It was not palpated. The oncologist had actually palpated her 4 months earlier. Very skillful oncologist. Still couldn't see it. It's a deep tumor. And if you look back a year, you can see it in this picture, the CT that I showed you a minute ago. You all seen it here. It's right there. You just have to look. So that screening and breast cancer management is not a simple procedure. Almost everything went well. It was a difficult tumor, seen at mammography but not ultrasound. The other one was seen at ultrasound but not mammography. Both were seen at MRI, but I misdiagnosed. This one, we didn't have the biopsy equipment, and we forgot about it. We got sidetracked by the other cancer. And adjunctive therapy did not prevent the tumor from growing rapidly. But it's still given just in case, you know. Yearly palpation failed. Had she had yearly mammography, as we have tried to get as part of the national recommendations for the past 30 years, unsuccessfully, it would have been found a year earlier. So, this is my final slide. The responsibilities of the screening program should include both screening and follow-up diagnosis and participation in the interdisciplinary management. And the training and detailed quality assurance are essential for a successful program. And the problems are typical. We all know about them. And we should overcome them with careful planning, good training, and effective quality assurance. Thank you.
Thank you very much for your very interesting presentation. Unfortunately, we do not have time anymore for discussions because we have one more presentation left. Mārcis, Leija, please. You have to be as short as possible.
Let's see now, how do we get rid of this one? It doesn't respond to the touch. It's just, it's there.
Okay, no, it's let's go. Okay, I will try to do my best to be fast. I have a few slides still, but it's true that we have to free up the rooms. But what I'm going to speak on the other cancer screening, and just to say that neither CONCON nor the European Commission is recommending it for the time being. But the question is, and the point is, where we stand now with this. We know that gastric cancer is one of the cancers, or one of the few cancers, that is declining rapidly in all over the world. But actually, what is different, the start point and the current point are very different all around the different countries in the world. And David Foreman, while still being in IARC, has made these estimates that we do have close to 1 million new cases annually now, and what he estimated as foreseeable future within the next 30 years or so, because the estimates were not made further, we are going to stand with these 1 million cases or also in this period, unless we are going to interfere with this. And why? Because of aging population, because of increasing global population, increasing and improving lifespan. Therefore, there was an expert group hosted by IARC at the end of 2013. The conclusions of the expert group was indeed that it has been a neglected disease and that it should be prevented, and we can prevent approximately 35 to 40% of gastric cancer deaths, approximately. This is more than important that the cancer is one of the infectious-related cancers, and Helicobacter pylori is the microorganism that is responsible for this type of cancer. In at least 90% of the cases, we could discuss about the proximal cancers. Non-cardiac cancers are not demonstrated to be exactly correlated, but there are controversies, and even the current guidelines say that also the proximal cancers, by excluding esophageal cancers, are linked to this type of infection. So we do have a very well-defined precancerous cascade, and that was proposed by Professor Pelayo Correa, who is still active at his 90th. But this is one of the models that has survived decades, since the first publication dates back to 1975. At the time when Pelayo didn't know about the cause of superficial gastritis and atrophic gastritis, only afterwards the Nobel Prize winners discovered that Helicobacter was responsible to this. But anyhow, what Pelayo Correa described is that from normal mucosa of the stomach, intestinal type of gastric cancer is developing through superficial gastritis, atrophic gastritis, intestinal metaplasia and dysplasia. But what is more than important, that only 1 to 2% of those that are infected with Helicobacter are developing gastric cancer lifetime. So can we prevent, and what would be the ways to prevent gastric cancer? And there are several approaches really that could be used to prevent, including primary and secondary approaches of screening, and even primary prevention could be divided in 2 completely separate arms. One is to reduce the transmission of the infection, also change the diet and lifestyle that are other factors that are responsible for gastric cancer development. That's what we know, that in the societies where less prevalence of the infection in the population, definitely there's less infection to be transferred to the offsprings, because the normal transmission occurs from the mother to the child. Additional or a different type of primary prevention is eradication of Helicobacter. And once more, this could be done in symptomatic patients. It could be done in particular risk at increased risk, but it could be also offered at general population, and I will come back to this. Means of secondary prevention would be to search for pre-malignant lesions or cancer at a stage it could be curable. And with the pre-malignant lesions, we are understanding atrophy and intestinal metaplasia, as well as dysplasia that is considered a high-risk lesion. So by considering this, there could be very different approaches to screening of gastric cancer, and we shouldn't really mix between those, because we can search for cancer itself and expect to find it in an early stage. We could search and screen for precancerous lesions and try to manage and survey individuals that have been revealed to carry these precancerous lesions, or we could search for Helicobacter and eradicate this not considering the presence or absence of precancerous lesions. So I will briefly go through these options and what is really globally done, or what is a global experience. We do have 2 countries that have a population-based screening approach, and these are Japan and South Korea. Until recently, Japan, the only mean of organized screening, the only method was X-ray, barium swallow, but I have to mention that it is done in a completely different way that it is being done in the West. Starting from this year, Japan, by looking at the good experience from Korea, have also accepted endoscopy as a primary method of screening, but that has happened only since this year. In South Korea, they accepted both the method, and there have been comparative evaluations between them, and endoscopy in general has been found to be superior than X-ray examination. There are minor other differences, but as you can see, for instance, the participation rate is higher for endoscopy, even if combined to X-ray, than just X-ray alone. There are few other countries that have tried to implement screening approaches. This is yet not organized, but more opportunistic. China is doing this in certain regions of the country, doing some enrollment with endoscopy. Costa Rica has been following the Japanese experience in few centers, and Kazakhstan has also declared to be introducing endoscopy screening, but that is really not fulfilling the criteria, and some of the people in some of our colleagues in the room can even explain more what is the situation there. In respect to the searching and treating for Helicobacter, We do have 3 cost-effectiveness meta-analyses. One of them was by the group from IRIS, who has been participating also in our meeting. The other from the Portuguese group, Miguel Larrea and his team, and the third by Paul Moyedi from McMaster University. All of these meta-analyses have been showing huge economic benefit of mass eradication for Helicobacter, but this has to be mentioned that we are lacking sufficient data on the potential adverse events still in the case if antibiotics are used in population-based settings, and this hasn't been considered sufficiently in these analyses. And no country has implemented the strategy so far. Japan has declared really of getting rid of Helicobacter, but that goes through the doctor's offices. The numbers are increasing, but it's not a population-based strategy. And as far as I know, Slovenia is really the closest country of implementing this strategy in real life. We do have few pilots. There's a huge study being performed in Linkou country in China, and definitely we are very interested to see the results of the study. More than 200,000 individuals have been enrolled and randomized to 2 different treatment options, but there's still way to go until we'll see the results. There's exciting data available from Matsu Island in Taiwan, although this hasn't been a randomized study, and currently 2 counties in Taiwan are also running pilots. These are the results of the mass eradication in Matsu Island, but it has to be mentioned that Matsu is a very specific population with very high incidence of gastric cancer. They have achieved 25% reduction of gastric cancer incidence, but once more, it hasn't been a randomized study. So what do we have in the guidelines? And we have a few of those. One is the global Kyoto consensus guidelines, and I will not go deep into the major statements, just to say that for the first time Kyoto global consensus is naming Helicobacter as caused gastritis and infectious disease, and suggesting that the individuals infected with the microorganism should be offered eradication therapy unless there are competing considerations and irrespective of the symptoms that the infection might cause. Further on, we have developed these considerations in the Maastricht 5 guidelines that have been just online published by the end of the last year. And Maastricht 5 is stating that screen and treat is a strategy that should be recommended in communities with high risk of gastric cancer. On the other hand, also the strategy should be considered in communities with intermediate to low risk of gastric cancer. In other words, both of these guidelines are calling for search and treat strategy in asymptomatic individuals. What is the position of European Council and the CONCON project? I will come back to this in a minute, but another issue that has to be emphasized and that seems to be very attractive is non-invasive screening for the precancerous lesions. And we do not have better parameters than pepsinogens. These have been studied quite extensively in Japan and also in Europe. The studies have been started by our friend Pentti Siponen from Finland, who has also added gastrin 17 to the panel. These tests are being marketed and available for commercial use, but actually we have to say that gastrin 17 unfortunately is not working in real practice. Pepsinogens are, and we do have a number of studies originating mainly from Japan indicating that decreased pepsinogens are linked to increased hazard ratio for developing of gastric cancers, and these are the major studies from Japan really stating the fact. Until recently, we did have the criticism that this is not reproduced in a Caucasian population. Now the situation has changed, and this is a recent publication from our colleagues actually in a Siberian city of Novosibirsk, but this is a Caucasian population in this city. Within the HAPPY program, they have collected quite substantial study population group, and by respectively looking at the samples and what they had 60 cancers identified, and that is not less than in the Japanese studies. They also found that decreased pepsinogens are related to increased risk of further development of gastric cancer. But what are the drawbacks? And this is our small study. Now the numbers have been increased substantially, but just to illustrate, and that is a fact also with all the other previous studies, there are increased odds ratio, hazard ratios for developing gastric cancer. But the question is, if we use pepsinogens as a screening test, what is the proportion of cancers we are identifying and what we are missing? Unfortunately, we are missing more than we are identifying. And this is how we looked at the gastric cancer cases, most of them with advanced gastric cancer. And overall, only 1/3 of them had decreased pepsinogen values. More than that, of course, we would expect that intestinal type of cancer would be linked to decreased pepsinogens in every single case, but that is not the case. Only every second case was associated to decreased pepsinogen levels, and gastrin 17 was really not working also in this study population. So by considering this, and going back to the criteria that are established by CANCON project to make the decision on whether to implement a new cancer screening program or not, first of all, we should really be aware of the effectiveness, and randomized clinical studies with mortality as an endpoint are required for this. Unfortunately, we do not have this for gastric cancer. And then further on, the implementation research should be performed in the target countries really to see whether this is working. So what we had concluded in respect to the gastric cancer, that we do have insufficiency of randomized clinical studies, that we do not have enough data on the potential adverse events in the case if to give antibiotic treatment to everybody. But there definitely could be the space for using preventive measures, and we might need to choose appropriate age groups. We might need to choose different medications. So what was concluded from CANCON recommendations that we definitely need additional studies, and actually such study is on the way. And we are currently involved in managing the study together with IARC principal investigators, and this is a study currently being conducted only in Latvia, but planned to be extended also further to other territories. We are enrolling 40 to 64 years old individuals, and after excluding any alarm symptoms, after making dedicated full questionnaire and general measurements, the individuals are randomized to two groups. Those with decreased pepsinogens are being referred for endoscopy, and those with identified Helicobacter infection are being offered eradication treatment in group 1, while both of the groups are just getting lab-based FIT test and being referred for colonoscopy in the case if they are positive. And for the time being, we have completed the pilot study in altogether 4 centers in Latvia. In 2 centers, the major study has been started, and we are planning to continue it in other centers in Latvia and also potentially outside. This is a situation and the timeline. We have started in the last quarter of 2013. The pilot study was completed by the end of 2015, and actually another pilot study additional to Latvia has been started in Kazakhstan just a couple of months ago. And these are the figures for Latvia. As for today, actually we have reached 4,500 recruited subjects, although the total target is at least 30,000. And preliminary results, the HP positivity has been quite high. Currently, I have to say that we have changed to breath test. It is a bit lower. Decreased pepsinogen levels definitely depend on the cutoff values that we are setting, but with the strict cutoff values, they are approximately 7 to 8%. And with this, I would like to thank you.
Sorry, I know everybody wants to go home, but have you got a high incidence of gastric cancer in Latvia?
In Latvia, for the time being, we are a high incidence country. Definitely the incidence is also declining in Latvia, but we are still among the high incidence countries. Not so high like in East Asia or like in Kazakhstan. They are definitely higher than we are. But we are still belonging to quite high incidence countries. And actually what is interesting that the prevalence of Helicobacter currently in Latvia is higher than in most of territories in China, Shanghai and Japan.
So, wow, but why is it declining? What is the reason for it to be declining? Is it because of early diagnosis of...
First of all, I think that the prevalence of Helicobacter is declining, and what we see that, for instance, in children, it is lower than it was years ago. If looking, for instance, Estonia have got very interesting data with 10-year interval in between. They also have found decrease of the infection in children. Definitely this is because of better sanitary conditions and because of decreased transmission, because really, of course, doctors are giving also eradication treatment in adults. We have quite substantial proportion of individuals that have been treated, that's also true. But still decreased transmission probably is a major mechanism why the prevalence of infection is declining.
Thank you, Professor. So we are coming to the end. I think the objective of this meeting is met. It was to provide decision makers in Latvia and Lithuania with principal outputs of cancer control project and particular related improvements in quality of cancer care and organized cancer screening. Thank you for everybody who came here, and now it is in our hands how to implement all suggestions what were said today for us. Really, thank you very much, and I hope that the collaboration will continue and you will be able to help us in decision making in nearest future. Thank you, Stefan, also for coming. Did you say something? How do you feel here in Riga?
Well, I feel very good in Riga again, and so it's been a big pleasure, and it's been a long day, but very interesting, and I've been kept awake the whole day. So it's been a real pleasure. Thank you for inviting me, and let's go for dinner.
Yeah, thank you. Thank you very much.